Hello, I am Dr. Shourdeep Dotto, MBBS and MS Obstetric and Gynecology. I am Senior Resident of UNINARY Medical College. Today I will discuss genuine stress incontinence in question answer approach. So our first question is, what is the main cause of genuine stress incontinence? Option A, weak pelvic floor muscle. Option B, weak pubourethral ligament. Option C, weak arcus tendinous fossa. And option D, all of the above. And option E is funneling of urethra. So our correct answer is all of the above. It includes weak pelvic floor muscle, weak pubourethral ligament, and weak arcus tendinous fossa. So in this context, I will discuss the pathophysiology of genuine stress urinary incontinence. So first of all, bladder neck support lost. So it causes the funneling of bladder neck. B, downward movement of bladder neck below pubococcygeal line. Below pubococcygeal line. C, posterior vesico-urethral angle increases or disappear. So it is the first proposed mechanism, and second is the hammock-like structure. Hammock-like structure that supports urethra lost. It includes anterior wall of vagina. 2, the intrapelvic fascia. 3, levator ani muscle. So during childbirth, levator ani muscle usually get injured, and intrapelvic fascia also get injured. It can also be injured in any pelvic surgery, forceps application, and repeated childbirth or vaginal delivery. And anterior wall of vagina, it is associated with pelvic organ prolapse. Let's see that picture. When the bladder neck support lost, the proximal urethra, that is intra-abdominal organ, it goes downward and get extra abdominal. It get extra outside the abdomen. So the abdominal pressure increases in bladder. Abdominal pressure increases in bladder. It get transmitted in bladder, and it get also transmitted in proximal urethra in normal cases. But when the proximal urethra get hypermobilized due to downward movement of bladder neck, then the pressure cannot be transmitted in proximal urethra. So it get easy funneling. So it causes incontinence. Secondly, this is the hammock-like structure. It includes pubococcygeal muscle, the anterior wall of vagina. It is hammock-like structure. It includes the anterior wall of vagina, the intrapelvic fossa, and the pubococcygeal muscle. So, if that hammock-like structure get injured, then urinary incontinence takes place. Another theory is pubourethral ligament. The pubourethral ligament, it supports urethra. So suppose it is urethra and bladder. The pubourethral ligament it supports urethra and it is attached with pubis bone. It is pubourethral ligament, and it is urethra, it is bladder. And if that pubourethral ligament get injured, or if then that the urethra gets hypermobilized. So stress urinary incontinence takes place. So in nutshell, 1, the funneling of bladder neck. 2, the injury of hammock like structure. 3, injury of pubourethral ligament. These are the main pathophysiology of SUI. Next question. What is the most common type of stress incontinence? The answer is genuine stress incontinence. So genuine stress incontinence, its prevalence is around 24 to 45% in more than 30 years female, and overflow incontinence, it has a prevalence of only 5% in chronic incontinence. And the mixed incontinence, it has 20 to 30% prevalence. And urge incontinence, it has 9% less than 45 years old female, and 31% more than 75-year-old female. So we can see that genuine stress incontinence has the highest prevalence, so it is the most common type of incontinence. What is the best conservative treatment for genuine stress incontinence? It is the pelvic floor muscle exercise. It is the best conservative treatment for genuine stress incontinence. So what are the other conservative treatments? So 1 is pelvic floor muscle training. 2, biofeedback therapy with vaginal pressure probe. 3, Kegel's exercise. 4, vaginal cone application. 5. Electrical stimulation of pudendal nerve. 6. Weight reduction. 7. Pessary. Pessary is indicated in pelvic organ collapse, and it can also correct genuine stress urinary incontinence. Other medications are, what are the medications? Medications are 1. Doluxetine. It is a SNRI. It is 40 milligram BD, and success rate is 50%. 2. Pseudoephedrine. It can reduce 20 to 60% of SUI, but it has a side effect of hypertension, so it should be avoided in hypertensive patients. And midodrine. 2.5 milligram TDS for 3 months. It is alpha 1 selective agonist. 4. Imipramine. It is 25 milligram TDS for 3 months. So the next question is, which of the following is common trigger for stress incontinence? The common trigger is, the answer is all of the above: laughing, sleeping, exercise, weightlifting, running, cough, sneeze, but not psychological stress. Question 5. Which of the following medical condition is not a risk factor for developing stress incontinence? The question is not a risk factor, so the answer will be chronic constipation. Some medical conditions that causes or that has some contribution in developing stress urinary incontinence, they are like chronic cough, not constipation, low estrogenic state, smoking, menopause. Whether it is natural or surgical, I mean TH, BSO or BSO. So our next question is, what type of incontinence is characterized by leakage of urine during physical activities? Urgent incontinence, mixed incontinence, overflow incontinence, and genuine stress incontinence. The answer is genuine stress incontinence. So in this context, we will know what are the types of incontinence. So we have this chart, and we have total 5 types of incontinence. 5 types of incontinence. 1. Genuine stress urinary incontinence. 2. Urge incontinence. 3. Overflow incontinence. 4. Mixed incontinence. 5. Functional type incontinence. And we have a DD of incontinence, that is fistula. Example, vesicovaginal fistula. So let's see this chart. We have discussed the mechanism of genuine stress urinary incontinence, and the patient typically present with a history of painless loss of urine concurrent with valsalva or any increased intra-abdominal pressure, no urge to void, and patient is conscious about the loss of urine. And the urge incontinence, it is associated with overactive detrusor muscle, and the urge component patient has typical complaint like she need to go to bathroom or toilet, but she cannot reach toilet within time. So she can here the patient has urgency and frequency. Patient has also nocturia, and the volume of urine is large. Here the volume is a little, and also in overflow incontinence the volume is low or little. It presents like dribbling, and here the in urge incontinence the patient is aware of that loss. Here also the patient is aware of the loss, but in overflow incontinence patient usually not aware of that loss, and fistula is not at all aware of the loss. Then treatment in genuine stress urinary incontinence, the treatment of choice is urethropexy or urethral sling operation, though the gold standard is Birch Colpo suspension. And in urge incontinence, surgery usually not done, usually avoided, because many times the surgery can deteriorate the symptoms or the total disease. So anticholinergic medications are preferred here, and in overflow incontinence we have typical history of diabetes or any spinal cord injury. So the patient always have a full bladder, and unknowingly some dribbling continues, and so the patient the main treatment of the treatment is mainly symptomatic, and we need to advise the intermittent self catheterization for this patient. So, and in fistula, then fistula usually has a history of any surgery or any prolonged labor, and the diagnosis is usually made by introducing a dye into the bladder and shows vaginal discoloration. So the treatment is surgical. Let's see the other question. Question number 7: can stress incontinence be cured permanently? Now look, it is very controversial question, but if we the question number 7: can stress incontinence can be cured permanently? The question is very controversial, but the answer is no, because even the gold standard procedure, that is Birch Colpo suspension, is not. The next question is, can stress incontinence be cured permanently? The answer is no, because even the gold standard procedure, the Birch Colpo suspension, does not have a 100% cure rate, and in long term the efficacy of the any operation, either it is TOT or any other sling operation or Birch Colpo suspension, in long term their efficacy goes down, and so the stress incontinence can never be cured permanently. Though this question is controversial. Can men develop genuine stress incontinence? Answer is yes. How? Uh, After prostatectomy for prostate cancer. So after prostatectomy, the patient can develop genuine stress incontinence, but in considerable cases, this incontinence get cured within. So it is reversible in considerable cases within 12 months. What is the most common surgical treatment for genuine stress incontinence? The most common surgical treatment for genuine stress incontinence is bladder neck suspension. The answer is A. So, in this context, we will discuss A, the bladder neck suspension. In this context, let's see what are the surgical options. So, the surgical options are suburethral sling operation, suburethral sling operation. It includes TOT, TVT. TOT is trans obturator tape and TVT is tension free vaginal tape. Tension free vaginal tape, and it is trans obturator tape. Another is mini sling operation. So let's discuss TOT and TVT here. So first discuss TOT. TOT is a 2 cm midline incision over the anterior vaginal wall. This is the anterior vaginal wall here, and a 2 cm incision is given, and the bladder is dissected away from vaginal mucosa. Then we just pass a TOT hook. We just pass a TOT hook from this incision, and the exit of that TOT hook is 3 cm away from external urethral meatus from here. Now, along with the TOT hook, the mesh is placed here, and this thing repeated on other side. These things repeated on other side, and the mesh is fixed below the urethra in tension free manner. So in TOT the success rate is 73 to 92%. Another is TVT. TVT is tension free vaginal tape. Here we give a anterior vaginal wall incision, a vertical incision, and a trocar with mesh is passed through that incision after dissecting vaginal mucosa from bladder, and the sling is brought out from two small incisions on lower anterior abdominal wall, and the routine cystoscopy must be done after that surgical procedure, as there is 6 to 8% chances of bladder injury, and its success rate is 87%. And this is a schematic presentation. The mesh is placed below the urethra, and it has been passed in retropubic fashion. So in TVT the success rate is more, but there are more chances of bladder injury and vascular injury. Next, come to the Birch colpo suspension. It is the gold standard procedure. Here, the vaginal wall adjacent to urethra and bladder neck is suspended using suture in a retropubic fashion to Cooper's ligament. We can see this is the Cooper's ligament, and the suture material has been passed, and the fossa associated with the urethra is gets strengthened with that suture that has been mount over the Cooper's ligament. So its success rate is 85 to 90% in 1 year and 70% in 5 years. So we can see that the success rate, even the efficacy is getting decreased in consecutive years. So we cannot say that the stress urinary incontinence can be treated permanently. So now come to the next question. How long does it usually take to see improvement of pelvic floor muscle exercise for stress incontinence? The answer is 1 to 3 months. 1 to 3 months. And how much time it takes for correction of stress urinary incontinence after TOT or TVT? The answer is immediately. The answer is immediately. After TOT, we will ask the patient to pass urine within 2 to 3 hours, and we will discharge the patient next day. Question number 11. Which is false about diagnostic test of SUI? The option A is the low peak flow rate, that is less than 15 ml per second with high dead-to-source pressure, and B is the maximum dead-to-source pressure is less than 15 cm H2O, and the option C is the capacity of the bladder is 400 ml to 600 ml, that is normal, and D is both A and B. E is urine culture sensitivity is normal. The answer is both A and B. Let's see what are the findings of SUI. What are the clinical tests, and what are the lab tests, and what are the urodynamic tests we done. In this context, we will discuss the diagnosis of SUI. 1. The clinical stress test. It is positive. 2. Pad test. It is positive, and what is it? It is increased weight of vaginal pad by 1 gram after 1 hour of non-resting condition. 3. Urine culture and sensitivity, it will be negative. 4. Bladder diary. Here we will ask the patient to plot frequency, volume chart for at least 3 days. 5. Q-tip test. If more than 30 degree upward elevation of cotton swab inserted in urethra during valsalva, then we can say that hypermobile urethra. What are the urodynamic tests? One, uroflowmetry. It should be normal in SUI. Let's see that question. If the peak flow rate less than 15 ml per second with high dead to source pressure, it is suggestive of bladder outlet obstruction, not SUI. Two, cystometry. So it should be normal in SUI. Here the residual volume will be 0 to 50 ml. The first sensation 150 to 200 ml, and bladder capacity will be 400 to 600 ml. Intravesical filling pressure will be 0 to 15 centimeter of H2O. Maximum dead to source pressure less than 50 centimeter H2O. Peak urinary flow rate more than 15 ml per second, and there will be absent systolic dead to source pressure. Others will be urethral pressure profile, that is lower urethral pressure in SUI. 4. Leak point pressure test. Positive with valsalva. 5. Cystourethrostomy scopy to rule out any swell or tumor if hematuria present. 6. Video cystourethropy. 7. MRI pelvis. 8. Transvaginal sonography. So we have completed our discussion on genuine stress urinary incontinence in question answer approach. Next day we will discuss the other urinary incontinence and other gynecological and urogynecological problems in question answer approach.